approach to a patient with HIV infection. So I need to tell you this very briefly, though I'm not going to go into the details of the pathophysiology or of the physiology of the infection, but it is important to realize that if we know how HIV enters into the body and how HIV infects the body, we will be able to understand what kind of clinical manifestations happen in this disease. So HIV is a sexually transmitted disease. It is important to understand that sexual contact remains one of the most important transmission modalities or methods of transmission of HIV. Though there are other methods of transmission as well, which include use of contaminated syringes or needles or sharing of needles and other paraphernalia which are used for injecting drug use, also from mother to her unborn child through the placenta, and also through transmission through uh, unchecked or unclean blood and blood products. So those three are very limited. However, the most important modality of transmission of HIV from person to person remains sexual, whether it is homosexual, that is men having sex with men, or it is heterosexual route of transmission. Depending upon the epidemiological setting, different types of sexual transmission occurs. So once HIV, we are talking about this pattern of infection is in reference to the sexual mode of transmission. So whenever the HIV or the human immunodeficiency virus makes contact with the cells which is located within the genital mucosa, so from there, with the help of these cells, which I will show you in the next diagram, which are the dendritic cells, the virus is carried to the regional lymph nodes, which would be the pelvic lymph nodes or the inguinal lymph nodes within 1 to 2 days. It is within these lymph nodes, which are there in the pelvic area, that exponential viral replication happens in the initial period. And as you can see that within 5 to 11 days from the lymph node, widespread systemic dissemination happens via the bloodstream to the brain, spleen, all the distant lymph nodes, all organs within 5 to 11 days, which means that once HIV enters into a person's body or in the genital area, it is transmitted or it is spread throughout the person's body within 5 to 11 days. So it seeds almost all organs of the body within 2 weeks. And that is very, very important for you to recognize that HIV infects almost all organs of the body within a matter of a few days after infection, acquisition of infection. And hence, since it seeds almost all organs and organ systems of the body so early, HIV can have myriad manifestations that affect various organ systems. So like I was telling you, this is the day 0. Suppose we think this is the duration of exposure, and you can see that these are the HIV virions which are entering into the mucosa. These virions are recognized by the CD4 receptors which the dendritic cell carries, and they also have CD4 receptor recognizing units. And so because of these, the dendritic cell kind of carries them or lifts them to the local CD4 lymphocyte, and from the CD4 lymphocyte, these go on to the regional lymph nodes. It is within these regional lymph nodes, they reach there within about 2 days, 2 to 3 days. Here, exponential multiplication and replication of the virus happens. And then these viruses within the CD4 cells are released into the bloodstream to seed the brain, the lymph, the spleen, the gut-associated lymphatic tissue, which is a very prominent early involvement because of HIV, and to the multiple other lymph nodes. So this is very important for us to remember and recognize as to what is the pattern of infection that is seen with HIV. So it is important to recognize that although one acquires an infection with HIV, after acquisition of infection, there is a varied period of time before the disease actually manifests itself. So it is not as if that that once a virus enters into the body, within 3 or 4 days, that patient will manifest disease symptoms or signs. That doesn't happen. It has a very varied and a very, very prolonged course. And these are the stages of untreated HIV infection. So once viral transmission happens, the first set of symptoms that may or may not develop is what is called an acute retroviral syndrome, This retroviral syndrome happens at about 2 to 3 weeks after viral infection is acquired. This usually corresponds to the period when the early viremia is happening and the virus is seeding all the body organs and organ systems, like I told you. This viremia produces a syndrome just like any other viral illness. So the patients will present with fever, with headache, with some amount of nausea, myalgias. It will be just like any other influenza-like illness. This lasts for a variable period of 2 to 3 weeks, depending upon the initial viral load. And what is important to remember here is that very few patients in this seroconversion reaction actually in this acute retroviral syndrome phase, or it is also called the acute HIV infection, they actually do not present themselves to a healthcare worker because they really don't know that this is related to acquisition of HIV unless it is a one-time risk exposure that has happened. So it is very important to recognize that if there is a source which is known, or there is one risk event which has happened, and 2 to 3 weeks after that, somebody does notice an acute retroviral syndrome, then one must think, depending upon the risk stratification of the patient, that it could be acute retroviral syndrome. In a few percent of patients, acute retroviral syndromes can manifest with more severe manifestations, and that would include things like neurological manifestations. They can present with acute inflammatory demyelinating polyneuropathy like GVS. They can manifest with a myelopathy. They can manifest with an encephalitis. But these are very limited and very rare. The most common manifestation, like I told you, of an acute retroviral syndrome is an influenza-like illness, which stays for a few days and then it settles down. It settles down, it is self-limited, it settles down on its own, and no active treatment is usually taken or sought for that. Why it settles down is what happens is seroconversion is happening. That means the body mounts an immune response to the incoming HIV virus. And this immune response, which is initially IgM and then later IgG, is able to control viral replication to a certain extent. And that virus, which was replicating in tremendous rates, is brought down to a certain level. And then it stays at that certain level after seroconversion happens. That means after antibodies develop in the person's body. This level of viremia, which is brought down to a low level and at which level it stays for an indefinite period of time, is what is called the viral set point. So initially the virus replicates tremendously, and then with the help of seroconversion, the viral replication is brought down to reach a viral set point. Why is it important to know this concept of viral set point as far as clinical manifestations are concerned? Is because of this. When the viral set point is reached, it means there is a delicate balance which is being maintained with viral replication and with the body's immune response. And the body's immune response is kind of able to balance out the viral replication. Since the body is able to balance out the viral replication, the patients generally do not manifest any signs and symptoms of HIV infection during this period. And this period is a rather long, protracted period, and it may last from anywhere from 5 years to up to 10 years. On an average, it is said that patients remain about asymptomatic for about 8 years after acquisition of the HIV infection. So for almost 8 years, 5 to 10 years is the range which is usually used in clinical settings or in epidemiological settings where there is not much of other infections in the background like TB or diarrhea, or the patient's health otherwise does not have too many comorbidities, then this period may be going towards the extended period, that is 10 years. But in countries like India, where TB is common, where malnutrition is common, where the general health comorbidities are multiple, this period of asymptomatic chronic infection may get reduced to almost 5 years. It is very important to recognize this asymptomatic chronic infection period because during this period, the person is infected with HIV. HIV is present in the person's body, in the blood, in the body secretions, but the patient is probably unaware of his or her HIV positive status. So this person during this phase of acute, or of the person of phase of asymptomatic chronic HIV infection can transmit the virus to his or her partners without even him knowing it or without the partner knowing it if there is um, unprotected sexual intercourse. So it is very important to recognize that this asymptomatic period is the period when the person does not manifest symptoms, so is potentially a very high risk of transmitting the infection in the community. After this asymptomatic infection period, which varies between 5 to 10 years, like I told you, the virus replication, which is happening continuously, simply overpowers the immune system. And the immune system is not now able to control this viral replication. Once that happens, and once the virus kind of breaks away from the control of the immune system or the immune response of the body, it will then cause severe immunosuppression, and this immunosuppression will then produce all the clinical manifestations of symptomatic HIV infection. And if untreated, this period from symptomatic HIV infection to a more late phase, which is called AIDS, happens in about 1 to 1.3 years. So if not treated within this period of time when the patient starts manifesting clinical symptoms, HIV will progress to AIDS, which is called acute, which will happen in about 1 to 1.3 years. And these patients, if untreated with AIDS or acquired immune deficiency syndrome, will die. So untreated HIV infection is fatal. It is very important to remember. And if we intervene with treatment, either at the acute retroviral syndrome phase or during the phase of seroconversion or any phase beyond that, and we start appropriate and optimal antiretroviral treatment, we are able to prevent the development of the more severe complications of HIV infection, and we are able to control all the morbidity and to large extent mortality that is associated with this infection. So now let us look at a typical course of HIV infection, which will show you two or three things together. This will show you what happens to the virus. This is also going to show you what is happening to the immune system or the immune response in two ways. What happens to the antibodies, that is what is happening to the humoral immunity, and what is happening to the cell-mediated immunity or the CD4 helper cells. And it is also overlapping with what are the clinical phases or what are the clinical manifestations that these patients have in HIV infection. I will take one of these graphs and I will show you one line, and I'll explain that to you as we start. So let us start with the simplest thing, which is the virus. All right. So like I said, the curve of the virus, the graph of the virus is shown in the pink line. And you please follow that pink line and it will tell you. So on this axis, we have the time duration. And on this axis, we have the HIV RNA copies per ml. So this tells you how many viral copies are there in the patient's body. So like I said, once HIV gets inside the patient's body or HIV infection is acquired, within 1 to 3 weeks, there is a rapid increase in viral replication and the virus reaches a maximum level, which is in the tune of billions and millions of copies very rapidly. By about 3 weeks, the viral level peaks. The viral level, which was zero when it was acquired, it peaks by about 3 weeks because of the rapid dissemination which is happening in the bloodstream to about millions of copies. After about 3 weeks, the virus starts coming down. The viral load starts coming down progressively. And this progressive decrease in viral load is happening because of this response, which is there in the dotted green line, and that is the antibodies which are developing. So once the antibodies start developing, they are able to control this viral replication. And this viral replication comes down and reaches a very low virological set point, which is called the virus set point. It's also important to remember that this virological set point varies from patient to patient. Some patients are able to have a lower set point, some patients have a higher set point. So this set point, it stays in the range of 0 to 100. at the set point for a variable period of time. Like if you see in this graph, it's in the period of years, and by about 5 years in this graph, what is happening, you can see, is that this viral set point, which was very low and mildly undulating, now starts showing a response and starts increasing. So by about 8 years, then there is a dramatic increase back in the viral load. So it is very important to remember that the virological response, which is reached its set point, remains like this for a very extended period of time, and then after some time, when it is not being able to control the body, it then shows a rise again in the viral titers. So this is what is happening to the virus. I told you that by about 3 to 4 weeks, we have seroconversion. The initial antibodies which are produced for the humoral response are always IgM and later IgG. And so by about 8 weeks, 6 to 8 weeks to maximum about 12 weeks time, the HIV antibodies are firmly established. And these antibodies, which start from about 3 weeks and reach to a peak at about 12 weeks, they stay in that patient's body lifelong. So this HIV antibody stays permanently in a person. That is why once a person is detected to have HIV infection, the antibodies always stay positive. You will never have a situation where a person is HIV positive, has HIV in the body, and the antibodies are negative. The antibodies remain for a very long time. However, they are not able to control the viral replication, and the reasons for that are very different, and they are not the mandate of today's session. The other important thing to see is what is happening to the blue curve. I would like you to focus on the blue curve and not on the pink lines in between. The blue curve shows you what happens to what is called the CD4 count. As you all know, the CD4 count is also called the T helper cell count. And normally, in a normal individual, like the normal CD4 count varies between 800 to about 1,200 cells per cubic millimeters. And so, in an uninfected patient, the CD4 count would be about 800 to start with. When the viral replication is at its peak during the acute HIV infection, the CD4 cell count also shows a slight dip in the numbers, but the numbers reach about 400, 500, maybe a little lower if this replication rate is very high. Once this replication is getting controlled by the immune system, the CD4 count again rises and may not reach the original peak value, but it rises and reaches a relatively well value such that the person does not have too many symptoms at this point of time. However, it is important to note that even though the viral set point is reached and there is not much serious viral load which can be detected because the set point is quite low in many patients, the patients start dropping CD4 counts. CD4 counts progressively drop in these patients throughout, and untreated, it may go down to very low levels. So even though after the acute phase of illness, that is acute HIV, CD4 counts have risen almost back to pre-morbid levels, after that, even though virus reaches a set point and viral replication is very low, the CD4 count shows a consistent progressive drop in its numbers. It is very important to remember this. Now let us try to correlate what is happening to the CD4 count and what are the symptoms that happen when this CD4 count starts falling. Like I told you, most of the symptoms happen when the CD4 count falls because these patients then tend to level up opportunistic infections or infections because of a weakened immune system. During the phase of acute HIV infection, since the CD4 count has shown a drop, many times patients can show influenza-like illnesses or sometimes other types of illnesses also, like I told you, rarely. But what is to be seen is that during the initial phase, when the CD4 count is dropping, during the early phases, when the CD4 count is still about 500, the person remains asymptomatic because a CD4 count of 500 is enough and good enough to warn away or wade away all the opportunistic infections. As the CD4 count falls further to about 300, 250, minor HIV related symptoms start happening. Once the CD4 count falls below 200, that is when viral replication has again gained momentum. This is when multiple infections, which are called opportunistic infections, appear in these patients. These opportunistic infections are very serious infections. Many of them are life-threatening infections, and untreated, they can cause death. And there is a wide myriad of opportunistic infections that can happen in these patients. And that is exactly going to be the topic of our discussion is how do these patients present? So if you see broadly, HIV infected patients can sometimes present with an acute HIV illness. HIV infected patients can present when they are asymptomatic and they are just picked up for having HIV infection when a test is done. These patients can present with minor HIV related symptoms, or these patients can present late with multiple opportunistic infections and full blown AIDS. So if you see over a period of years, people living with HIV have numerous clinical manifestations and clinical features with which they can present to the healthcare system. I would like to emphasize again that when they are asymptomatic and if they are tested at this point of time, it gives us a very important window of opportunity to manage these patients before they develop all these opportunistic infections and they are able to survive for very long periods of time. So this pattern of progression that we saw, that the CD4 count is falling and patients go on from asymptomatics to symptomatic to AIDS, this pattern is the usual pattern. But there are patients, this is called the typical progression, which happens in about 50 to 70% of patients who are HIV infected. And these about 35 to 50 CD4 cells per year. And since they are dropping about 35 to 50 CD4 cells per year, remember if a person started with 800 cells, they will develop end stage within about 8 to 10 years of seroconversion. So this is how a typically person infected with HIV will progress. But what is more dramatic are what are called rapid progressors. These are very few. These are about 10% of PLHIV who present as rapid progressors. These patients drop 50 cells per month. Remember, this person was dropping 50 cells a year. These patients tend to lose about 50 cells a month. So in a year, their CD4 count would come down from 800 to 200 because they have lost about 600 cells. So within 1 to 2 to 3 years, of acquiring the infection, these patients develop symptoms of AIDS and end-stage HIV disease within 2 to 3 years of infection. This dramatic and rapid progression is usually seen, especially when disease is acquired in infancy from the infected mother, and it is also seen in some other subgroup of patients, especially who have other comorbidities like tuberculosis or other malnutrition. So these rapid progressors have a very rapid systemic presentation on clinical presentation. Then there are others who are called slow progressors or long-term non-progressors. These are very few. These are less than 5% or 5 to 10%. Here, the CD4 drop is very slow and they tend to maintain their CD4 counts at about 500 to 800 for inordinately long periods of time. Why these patients do not drop a CD4 count, why the virus is not able to replicate so effectively in them is a matter of lot of research, and we still don't have the answers to that. But these patients are able to live stable lives for very extended periods of time, even if you don't start antiretroviral treatment in them. However, now the rule is that now the general recommendation is that anybody who is HIV infected, whether symptomatic or whether asymptomatic, irrespective of viral load or CD4 count, needs to be started on antiretroviral treatment. So that is the situation. So you must know that these are the progressors. This is the pattern of HIV progression once a person acquires an infection. So let us look at what are we going to do with these patients. Let us look at the first assessment that we will see. Once the patient presents to you for the first time with HIV infection is when you will see that patient has HIV, and then what are the things you would like to evaluate in that patient. So an assessment of an HIV infected client is the same as that you would do for any other person that you see in an OPD or in a ward or in an emergency setting. You do a clinical assessment, then you do a laboratory assessment after your clinical diagnosis because you need to make a plan of what all investigations need to be done for the person. Then There are certain other important aspects of assessment which we generally tend to ignore, or generally because of a lack of time we don't do that, but it is very important to assess these here. What is the social structure and support available for the patient? Because it is a very long term disease which requires long term commitment on part of the patient, and treatment fatigue can set in very quickly. And what is the psychosocial support and assess for the patient, and you need to assess that in detail, because that also impacts and influences not only the treatment plan but also the outcome of the patients. So what does this assessment lead to? Once you've assessed this patient, what are you going to do? So we are going to do what is called the staging of the HIV infection, and we'll talk about that a little later. After we have done our clinical evaluation, we stage the patient. Once, as part of the staging, we are able to screen and diagnose whether there is any ongoing opportunistic infection in the patient. And if there is an ongoing opportunistic infection, depending upon the immune suppression in that patient, we need to treat that opportunistic infection very early. We also try to determine psychosocial factors that may influence the disease. For example, the patient may be an active substance abuser or an active injecting drug user. So that may seriously influence the patient's adherence to treatment as well as adherence to clinic visits. So it is an important thing for us to realize. We also have to assess, after the clinical assessment, the readiness for antiretroviral treatment, because remember, antiretroviral treatment is a long-term disease, is a long-term treatment. Once you start antiretroviral treatment, you cannot and you will not stop antiretroviral treatment. So you have to be sure that the patient is ready and committed to the lifelong treatment with antiretroviral drugs. And also, since these patients are at a risk for developing opportunistic infections, even if they don't have one now, we need to give what is called opportunistic infection prophylaxis. And there are certain criteria that are there to determine eligibility to receive such OI prophylaxis. And that is part of what we do after the assessment. So clinical assessment, like all of you know, consists of two parts. There is a history taking and there is a physical examination. There is nothing very dramatic about clinical assessment in these patients. Clinical assessment is the same as that is there for all other types of clinical assessment is the same as that is there for any other type of clinical assessment, and it includes a history taking, it includes an examination, and it includes a, like you do for all other patients. There is nothing new or nothing special about this kind of clinical assessment. So let us look at what are all the components of clinical assessment. I hope I am audible. I'm not even sure whether I am audible and I'm being seen. Can anybody answer this? Is the screen visible? Am I audible? Yes, audible perfectly. Thank you so much, guys. Thank you. All right. So what we are going to do now is, let us try and look at what are some of the specific things that we need to do in history taking or in physical examination that are specific for HIV infection that we need to do, that will answer our earlier questions of how to stage, what to stage, and how will we go further. All right. So let us look at history taking. So these are some of the important points that one should keep in mind while taking a history, especially in relating to HIV infection. You will obtain a general medical history like you do for any other patient, and you will also ask some questions which are HIV specific. All right. You should always use a vocabulary that the patient can understand regardless of education level. And this is especially true in India, where we find that not all of the patients understand every question that we put to them. So the questions that we put to them must be in a language that they are able to comprehend and understand and give a response back. We must document that the patient is HIV infected on the basis of the tests and which test is done. It is very, very important. It is not enough if a patient just walks into your clinic and says that, look, I am HIV infected because I got tested 2 years back. So you please start me on treatment. So you need to reconfirm whether or not that test has happened, and you need to reconfirm your diagnosis, because remember, it is not like any other simple illness, but you need to reconfirm your diagnosis. Remember, many times Patients have gone to multiple other doctors, have consulted many physicians, and you need to know whether what kind of treatment patient has received in the past, whether patient has received any form of antiretroviral treatment, because that can, to a large extent, influence what kind of drugs you are going to prescribe now, and look at the general pattern of illness which patient has suffered before coming to you. So you need to review previous medical records and from past medical providers if they are available to you now, or at least if the patient is not carrying it on the day the patient visits you for the first time, you can always ask the patient to bring all the old records on next visit, on a subsequent visit, so that you can review them. It is very important to review the patient charts of, irrespective of HIV, whichever disease, you need to review patient charts. And also, it is very important that the clinician should always establish a supportive environment that facilitates the discussion of sensitive issues and is conducive to the building of trust. Remember, there is a lot of stigma attached to a diagnosis of HIV infection. Many patients will still not talk to you very openly about their sexuality. They will also not talk to you very openly about how they have acquired the infection or what do they think of their self-reported risk. Many patients who use drugs or who are substance abusers will not are not likely to open up about their substance abuse. So remember, it is very important that you may not get all the answers that you're looking for on the first interview. And if you are probing and if you are kind of too probing and too inquisitive and trying to ask too many questions on the first time, you may not get the responses that you're looking for. And also, you may not get back the patient for a subsequent visit. So that is not something that we want. We want to keep the patient in the health system, and we want to provide and support the patient through his or her illness. So it is very important to build a rapport. Many times you will find that patients will open up to you only on subsequent visits, and they will tell you more and more about themselves over a period of time. So if you keep that conversation going and flowing, and if you build up that trust, it is very, very important, especially in the context of HIV infection, to remember that when you are building upon history taking. So the component of history should be like you do for any other history taking. There should be a history of presenting illness. What has brought the patient to the hospital now? That is what is presenting complaints. Why has he come to you now, today? Why has the patient presented now? You do a detailed assessment of these complaints. Then you ask specific HIV related history like diagnosis, treatment history, other OIs. You look at past medical history, and you will also talk about all other components of history taking. In the history of presenting illness, you ask the patient to list out his or her presenting illness. What has brought you to the hospital today? You will list them in chronological order. He may not list you. He probably will not list you. You need to put them in some kind of an order, either ascending or descending order. And then later you do a detailed analysis of each complaint. And then you ask associated complaints along with it. You should always specific. If the patient even does not tell you, ask or inquire for involvement of each and every system in this manner. Ask about fever, anorexia, weight loss. Always ask, even if the patient does not have or does not report to you. Ask whether the patient has ever had a skin rash, a pruritus, any other skin disease, any other lesions, and this will include genital lesions as well. Look and ask whether there has been a change in vision, blurring vision, double vision, flashes of light, loss of vision, watering from the eyes, redness. Remember, patients may not associate skin disease or eye disease with HIV, but you know that HIV can affect the skin, it can affect the eyes. So you need to find out whether the patient has had or is having any of these complaints. Ask for ENT kind of involvement in the form of dysphagia, odynophagia, dental pain, hearing loss, something like that. Always ask symptoms relating to pulmonary system involvement or respiratory involvement. Ask always about cough, dyspnea on rest or on exertion, hemoptysis, expectoration, chest pain. Remember, TB is the most common opportunistic infection seen in people living with HIV, and you must rule out TB in all patients at all visits. So you must ask these questions to rule out TB. Ask about chest pain, palpitations, exertional dyspnea, pedal edema, because these can be some of the comorbidities seen on these patients. But remember, most HIV infected patients who are symptomatic will come to you with a fever, anorexia, and weight loss. Ask about nausea, vomiting, and diarrhea. Remember, in countries like India, gastrointestinal manifestations are so common that almost 70% of PLHIV in India will have diarrhea at some point of time. So always ask about diarrhea. And you can also ask about bleeding PR, especially in patients who are having, who are men having sex with men. They tend to have anal infections. They tend to have rectal infections. So you need to ask about all these things. Ask about any abdominal swellings. They could indicate an organomegaly. Ask about any lumps that the patient could have felt anywhere on the body. Always ask about jaundice, because many of the PLHIV also tend to acquire other transmission related, other transfusion related illnesses, or other diseases like, for example, hepatitis C or hepatitis B co-infections. Always very straightforwardly and pointedly ask about vaginal discharge in a female, penile discharge in a male, vaginal pain in a female, dysuria, genital or rectal warts or ulcers. You have to be very direct in asking questions about an STI, because many times you will find that patients do not divulge about an STI to you. So you have to ask them pointedly, have you ever had an STI? What type of STI was it, and what treatment did you take? Always ask about obstetrical and gynecological assessments to be done. Ask about vaginal discharge or bleeding. When was the last pap smear done at all, if it was done? How many pregnancies have occurred prior to this? What was the type of birth? What was the outcome of the birth? Was any MTP ever done? Has contraception being used currently? How many live births does a woman have? Are the children infected? All have the children been tested at all? So these kind of questions you need to ask. Ask about muscle weakness, muscle pain. Many of them will complain of fatigue, anorexia, generalized weakness. So it is important. You may need to ask about neurological symptoms of tingling, burning pain, numbness in the extremities, weakness, headache, focal neurological deficits. Headache is a very prominent thing to ask about. Focal neurological deficits, seizures. These are very important questions that you need to ask about. Then you ask about whether the patient has been seen earlier by any other healthcare institution, and when was the diagnosis of HIV made, where was it made, has the patient ever had tests. Remember, if the patient has been treated earlier and is coming to you, the patient will have a fair idea about viral load and CD4 count, and we encourage that. We always encourage that our patient should know what is a viral load, what is their last viral load, what is their last CD4 count, because it tells you about the involvement, and it encourages and facilitates involvement of the patient in his or her treatment. So we always encourage that. And if not, at least review the records. Has the patient ever had any antiretroviral drug, and what were the regimens which the patient had? Were there any previous adverse events to any antiretroviral drug usage, so that you can avoid the same drugs in your current regimen? And any other, for example, if you gave Septran or cotrimoxazole for prophylaxis, did the patient manifest any allergic reactions to it? So you need to ask these questions pointedly and directly, so that you are able to get an appropriate response. Ask about specific disorders that you want to know. You want to know about shingles. Shingles are also called herpes zoster. You want to ask about diarrhea, seborrheic dermatitis, oral thrush, or any other AIDS defining illness. Always ask about TB. It is very important. Ask your patient, did you ever have TB? Like I have written down later. Always ask about an STI. You have to ask it openly. Have you ever had a sexually transmitted infection to both your male and female patients? If they say yes, ask them what was the type of infection that they had. They may not know the diagnosis, they may know the diagnosis, but they may not know it. At least they will tell you the symptoms and signs, so that you can have your syndromic approach to STIs working in the back of your mind. Always ask for TB, whether in the past, whether in the present, whether the patient took ATT, what kind of ATT, did he complete his ATT? TB is a very important question to ask about, and I don't want to talk more about it because it is so important that it is a lecture in itself. But always screen with what is called the 4 symptom screening for tuberculosis. It is a clinical screening. It is not a lab screening. This is a WHO recommended clinical screening, which is called 4 symptom screening, also called the 4S screening for tuberculosis. And if the patient has any one of the following: fever, cough, weight loss, or night sweats, then the patient gets labeled as a TB suspect. And then all TB suspects are actively evaluated for tuberculosis. So remember, the 4S screening for tuberculosis will help you identify a TB suspect in a person living with HIV. Always ask about hepatitis and hepatitis vaccines if patient has received, especially for B. And if patient is hepatitis C positive, nowadays, since the government of India has started a hepatitis C program, has the patient ever received DAAs for treatment? Inquire always about psychiatric history and whether the patient has had any illness, previously diagnosed psychiatric disease, previously diagnosed or currently ongoing psychiatric disease, whether there are other disabilities, whether there has ever been suicidality. Remember, there are many drugs, especially the ones which we used to use in the past, like efavirenz, which have an increased propensity to cause neuropsychiatric manifestations. And these are drugs you would like to avoid in these patients. Also, the presence of active ongoing psychiatric disease is always a hindrance to adequate clinic visits and adherence to antiretroviral treatment. So you need to identify this important barrier of adherence to antiretroviral treatment. Ask about any transfusion or blood product history. Ask about sexual history. What are the sexual practices if the patient has anal sex, oral sex? It is important to know because these are important risk factors for HIV transmission, and they are also important risk factors for continued transmission of HIV from this index patient into the community. If the patient has gender identity issues, please discuss out with him how many patients and how many partners the patients have had, past and current. What is the risk behavior, whether condoms are used during each act of sex. These are questions that you need to ask. And so if you understand, some of these questions are not very easy for patients to reply on a first visit or a first assessment, and you need to really build up your trust with the patient so that the patient actually opens it with you, especially relating to homosexual behavior, homosexuality. These are not issues that patients like to discuss openly with you on a first visit or a first meeting. But some patients are very clear about who they are and how they feel, and they will tell you that. But not all patients. Many patients have a lot of hesitancy in talking about these issues. Substance issues, past and present, what type of drugs, whether they were street drugs, whether they were prescription drugs which were being illicitly used. We tend to think of drugs only as heroin or cocaine or marijuana or opium, whatever. We tend to forget that alcohol is a very important substance abuse phenomenon. Lots of patients who are HIV infected are abusing alcohol, and that is another thing that we need to address. Remember, smoking, tobacco history is also a form of addiction. It may not have immediate manifest influences so early on, but it does tend to tell about an addictive behavior or a pattern or a behavior towards addiction in these patients. If patient is using or sharing paraphernalia of IV drug use, that is also very important, and that needs to be identified. We need to identify all this because we not only are treating the HIV, we will also refer these patients to appropriate substance reduction program, which is available for all patients, and you should try and get these patients off the substance that they are abusing. There are programs within the National AIDS Control Organization which at least try to get off the patients from their IV drug use to oral substitution treatment. So OST clinics which help patients avoid IV drug uses to oral drugs is something that is called opiate substitution treatment, and OST clinics are working together with HIV clinics all across the country. After this, you assess the functional status. Is the patient able to go to work? If it is an adolescent, is the child going to school? Does the woman or does the man able to do his housework? Or is the patient ambulatory, meaning the patient is able to walk around but is not able to do any work because of the illness? Or the patient is completely bedridden. So this will tell you what is a functional assessment of the patient and how sick the patient is, and amount of day-to-day care needed, and you need to identify who is the caregiver for such a patient. Then you come to examination. Examination, like all other examinations, consists of two parts. There is what is called a general physical examination, and then there is a systemic examination. All right. I was looking at some questions given by some of you. I will try and take them at the end of the session. If you have any questions, you can please type out on your chat box, which is there. And I saw one question which was written, and I will address that question once I come back to it. All right. So on examination, you will do an assessment of the vital functions like you do normally. You will look at the pulse, blood pressure, temperature, and respirations, and these provide very vital clues about the functional status of the patient and exactly how sick the patient is. You will do an anthropometry. It is very important. All patients must have a weight, height, and you must calculate BMI in all your patients. Please do not forget to measure weight, height, and then calculate a BMI for your patients. Nowadays, there are so many applications available on a mobile phone. Otherwise, there are even machines which will tell you directly the BMI. So you really don't have to do much maths. But please try and calculate BMI for each patient. It tells you a lot about the patient's status and also provides vital clues about what is a likely outcome. We know that patients who are severely malnourished have very poor outcomes even after starting antiretroviral treatment. So it is important for us to recognize that. But if you're doing a more detailed assessment, you're doing a part as a research or whatever, you can do a mid upper arm circumference, a tricep skin fold thickness. They will provide additional information regarding the muscle and the fat content in the patient. And so it is important, if you're on a research mode, you need to do this. Please examine the general physical examination. Specifically, look at the hair, eyes, the skin. Look at the lymph nodes. Each and every lymph node you have to palpate. Look at the oral cavity. I will show you how the oral cavity can provide us so many vital clues about what is happening to the patient. Look for pedal edema if the patient is bedridden. Look for sacral edema, as fluid tends to collect in this around the sacral area in patients who are bedridden and not ambulatory. And always do a detailed ENT examination as part of your general assessment. In the oral examination, look for each and every one of these things. Look for oral candidiasis. Oral candidiasis or oral thrush manifests as white lesions which are seen, curdy lesions which are seen in the mucosa, over the tongue, over the dorsum of the tongue. These lesions can also be seen in the fauces, posterior pharyngeal wall, and even up down the pharynx. You can see these lesions. Oral hairy leukoplakia is usually seen on the lateral borders of the tongue, and I will show you these pictures as we go along. Look for gingival and periodontal disease, and patients tend to have a lot of gingivitis and poor dental hygiene. Look for abscess ulcers. That may be one of the manifestations with which patients present. Always look for oral herpes simplex. It again tells you it is a disease indicating event. Look for suspicious lesions, though they are very rare, but sometimes you can have violaceous or reddish lesions which happen and which could be Kaposi's sarcoma. Do a general, follow the general scheme of examination for each and every system. Look at inspection, look at palpation, look at percussion, look at auscultation of all the systems. Focus on the symptoms whose involvement is suggested by the history. For example, if a patient complains of fever and chest pain and cough, your examination will focus more on respiratory system. However, that does not mean the other systems cannot be involved. So please examine all systems. All systems in all patients. This is the dictum to be followed for all cases. HIV, non-HIV, whenever you are examining a patient, you must examine all systems in all patients, though you may focus more on systems whose involvement is suggested by the initial complaints. In the pulmonary examination, examine the lung fields for wheeze, rhonchi, rales, or any dullness that is there on percussion. Cardiac examination, look at the heart sounds, look at the heart rhythm, listen for any murmurs, any clicks or rubs. And this is nothing very specific for HIV, but this will tell you a lot of information. Examine for hepatosplenomegaly, any other masses, lumps, lymph nodes, whether you can feel it, and it is very important. Always examine for free fluid and ascites. They may have diagnostic importance in these patients. Neurological examination needs to be detailed. You need to examine the mini mental status examination of the patient. Remember, like I told you, HIV infects the brain very early in the disease, and these patients may develop long-term complications like dementias, like AIDS, HIV-associated neurocognitive decline. So these patients can develop all these symptoms. So it is very important for you to do a detailed mental status examination in these patients. Also, also examine the cranial nerves, examine the sensory and motor functions, do a cerebellar functional examination. Always screen for depression and anxiety. You may need to send these patients or refer these patients to an appropriate psychiatrist if you feel that you will not be able to tackle or handle that. You must do an ophthalmological evaluation, especially if patient is complaining of ocular symptoms, or you may refer the patient to an ophthalmologist for a more detailed examination. Please do a genital examination, or you may need to refer the patient to a dermatologist. Always examine for any warts, any herpes simplex lesions, any ulcerative genital disease, any discharge which is there, and a pelvic examination, or consider a gynecological opinion if you want to get it. Especially in patients who are MSM, look for visible anal lesions or evidence of any skin abnormality along the anus. So it is important that you remember about certain general points for assessment. It is very important to gain the trust of the patient and establish a good rapport before you take a detailed history. Patient may establish their own associations. For example, I went to my sister's house on Raksha Bandhan. On that day, I developed a fever. So you know it's not because of that, but it is the association with the patient gives. So you need to apply your mind to that. Respect the patient's sentiment, whatever he says, don't brush it aside, but use your discretion to see whether that association is viable scientifically or not. Though letting patient tell all or his complaints, you need to always keep a check on where the dialogue is going, because you need to keep the discussions on track so that you are able to focus all your energies on getting a diagnosis made and doing a good clinical assessment. Always ask relevant history, not only to rule in, but also rule out conditions. It is important. Personal history, sexual history, addictions, like I told you, are very sensitive matters that need to be handled with a lot of sensitivity and care. And spend time with your patient, and patient will tell you about them if the patient feels comfortable and when the patient feels comfortable. When you're doing an examination, make sure your hands are warm. This is especially in winters when we tend to have cold hands. Just rub your hands and then make the patient feel comfortable. Make sure your room is warm, and you explain the procedures to the patient. When you're performing a genital examination, perianal examination, you have to explain the procedure in detail to the patient, and if patient refuses consent, you cannot do it. You will document it that patient refused consent, but you will not do an examination unless patient allows you to. Remember, this is very important. Sometimes the patient may be too sick or too ill for a detailed assessment. Patients who come into the medicine emergency, or who are brought into the emergency in unconscious state, or who are very sick, you don't have the time to do a detailed general physical examination, systemic examination, history taking. At this point of time, you do a very quick assessment of the patient to see whether patient, what are the vitals, and your aim here is to resuscitate the patient first, and then at a later time, when patients, your resuscitative attempts and measures have been successful, you can reassess your patient and re-examine the patient after some time, and that time is very variable depending upon what the patient clinical condition is. So such a detailed examination may not be possible in all patients at all times, so you need to remember that you need to mold your assessments very quickly to what is happening. So after you have done this assessment, after all this has been done, you are now going to stage your patient. All right. And now we will talk about what is the staging of HIV that is available. I'm trying to look for the question. If anybody has put up any questions, I am not able to see. Yes, there. The invisible. All right. So we will come back to the questions a little later. Okay. So now, after this, we come to what is called staging of HIV. We have looked at the patient, taken a history, done a physical examination, then we stage the infection. So WHO clinical staging is what is followed in India. There is also a CD4 clinical staging. That is not followed by our national program. The WHO clinical staging is what is followed by our national program. And according to this, the HIV infection is staged into 4 stages: stage 1, 2, 3, and 4. This is a clinical staging. This does not have any lab assessment required. as part of the staging. And I'm talking to you about the adults and children. There are both staging available for adults and adolescents, and there is a staging available for children as well. There is not much difference between the two. Only thing is there are certain diseases which are added on for children, which are usually not encountered in adults. WHO clinical stage HIV stage 1 includes all those patients who are asymptomatic or who present with what is called PGL, or persistent generalized lymphadenopathy. So suppose there is a patient who comes to your OPD and says, "Doctor, I'm all right, I have nothing, but I went in for a routine checkup and they told me that I am HIV infected according to my reports. I have no complaints. I have no complaints at all." So that patient will be WHO stage 1. All right. Or if a patient presents with PGL, defined as painless enlarged lymph nodes, which are more than 1 centimeter in size, in 2 or more non-contiguous areas, persisting for 3 months. 1, 2, 3. More than 1 centimeter in size, in 2 non-contiguous areas, persisting for 3 months, for which you don't have a diagnosis, that is labeled as PGL. And patients who have persistent generalized lymphadenopathy also come under the stage of WHO clinical stage 1. WHO clinical stage 2, I have given both the adult staging as well as the children staging, but my focus here is going to be on staging for adults. Any adult with HIV infection who presents with moderate unexplained weight loss less than 10% of measured body weight or prior body weight, recurrent any of these, all right, not all of these, any of these, recurrent upper respiratory tract infections in the form of sinusitis, tonsillitis, otitis media, or pharyngitis. Remember, these are all upper respiratory infections. Presence of herpes zoster infections, angular cheilitis, recurrent oral ulcerations, a very specific entity called papular pruritic eruptions, minor fungal nail infections, seborrheic dermatitis. All of them come under stage 2. All right. Anybody, if you see from stage 2, this patient is having some moderate weight loss and mild symptoms. So if you remember in that graph, it was on the downward curve of the symptoms. All right. In addition, if children have unexplained persistent hepatosplenomegaly, extensive molluscum, persistent parotid, or lineal gingival erythema, these are also very characteristic of stage 2. But remember, for an adult, any adult with herpes zoster, any adult with angular cheilitis, or recurrent oral ulcerations, or fungal nail infections, or seborrheic dermatitis becomes stage 2. Stage 3 patients have more severe disease in the form of weight loss more than 10% of the body weight, sorry. They have unexplained chronic diarrhea for more than 1 month, unexplained fever, which could be intermittent or constant for longer than a month. Presence of oral candidiasis puts the patient in stage 3. Oral hairy leukoplakia again stages the patient in stage 3. Any pulmonary tuberculosis puts the patient into stage 3. Remember, pulmonary tuberculosis, not extrapulmonary tuberculosis. And low severe bacterial infections involving any organ like a pneumonia, empyema, pyomyositis, bone or joint infection, meningitis, bacteremia. All this puts your patient in WHO clinical stage 3. Also, acute necrotizing gingivitis, unexplained anemia less than 8 grams, unexplained neutropenia less than 500 cells per cubic millimeters, or unexplained chronic thrombocytopenia less than 50,000, again puts the patient in WHO stage 3. So these are all some WHO's clinical stage 3 defining illnesses. Then comes stage 4. Stage 4 is defined by these severe, very critical illnesses. HIV wasting syndrome, important illnesses like pneumocystis pneumonia, recurrent severe bacterial pneumonia. Remember, one pneumonia was stage 3. If the patient recurrently has severe pneumonia, bacterial, it is stage 4. Chronic herpes. Remember, acute herpes of any duration was stage 3. But here, chronic herpes more than 1 month is stage 4. we saw that oral candidiasis was stage 3, but esophageal candidiasis or other forms of pharyngoesophageal candidiasis, tracheal candidiasis is stage 4. Extrapulmonary TB is stage 4. So if a patient has a pleural effusion, it becomes stage 4. If a patient has one single lymph node which has TB, it is classified as stage 4. Many other serious infections which you would have heard about but would have not seen, like Kaposi sarcoma, CMV or cytomegalovirus infections, central nervous system toxoplasmosis, HIV-related encephalopathy, severe cryptococcosis including cryptococcal meningitis. It is a yeast which gives rise to chronic meningitis. Disseminated non-tuberculous bacterial NTMs like Mycobacterium cancerci or Mycobacterium abscessus. They will also be WHO clinical stage 4. PML, which is a form of a neurocognitive decline, which is seen in these patients. Chronic diarrhea is because of organisms like Cryptosporidia, Isospora, again stage 4. Disseminated fungal infections. We saw that nail infections were stage 2, but disseminated infections involving the lung or the GI tract will be stage 4, like histoplasmosis, coccidiomycosis. These will be stage 4. Any malignancy, especially a lymphoma, will be stage 4. HIV-associated nephropathy, cardiomyopathy, invasive cervical carcinomas, atypical disseminated leishmaniasis, all classify these patients as stage 4. Don't worry about this classification. It is available online. This I have taken from the NACO ART guidelines, which were published in October 2018. But this is available on public domain in the WHO guidelines. They are freely available. If you want, you can access them. Don't worry too much about these, but you should know what disease entity or what clinical diagnosis puts a patient in what stage. All right. So this is what I was talking to you about. What is the staging? So at the end of your history and physical examination, you should be able to stage your patient, because remember, the staging that we use in our setting is a clinical stage. All right. So you should be able to stage your patient with HIV infection. So let us look at what are opportunistic infections, because many PLHIV will manifest with opportunistic infections, and that is what leads to the myriad of clinical presentations. So what is an opportunistic infection? I have given you an idea in the tables as what kind of opportunistic infections can happen and what are they. So an opportunistic infection, by definition, is a disease that is caused by a microbial agent in the presence of a compromised host immune system. So remember, opportunistic infections are not only seen in HIV, they can be seen in patients with other immune suppressive conditions, like, for example, on steroids, like patients on solid transplants and receiving immune suppressive treatment, any other cause of immune suppression, like diabetes, like alcohol, all of them, when these patients manifest infections with a microbial agent, they are called opportunistic infections. OIs, as they are called, generally happen when the CD4 count of the patient starts declining, means the patient's body is not able to mount an adequate immune response. And it is important to note here that depending upon what CD4 count patient has, you can actually predict what kind of OIs will happen in the patient. So it's a good guide to estimate or to assess what kind of OIs can happen in a particular patient. And it is very important to know about what OIs happen and when they will happen, so that we can manage these patients, because we are able to give prophylactic agents to prevent opportunistic infections for a wide variety of infections, and we will talk about them very briefly, though I will not go into much detail. Like I said, you can predict what kind of OI will happen in a patient with HIV depending upon that person's CD4 count. So there is a very good association which is seen between the opportunistic infection and between the CD4 count. So if you look at this graph, it will tell you what is happening. This is the CD4 count in a patient, and this is time. So as we know, as time goes by, the CD4 count falls unless, of course, the patient is being treated. So see if you can see that beyond a CD4 count of about 450 or 500, patients will remain asymptomatic and they generally do not manifest any opportunistic infection, generally, all right? Once the CD4 count falls to about 400 to 500, you have minor infections like herpes zoster, herpes simplex, and others happen. When the CD4 count falls further, tuberculosis starts. In the initial phase, it is usually pulmonary TB. As immune suppression increases, it becomes disseminated TB, extrapulmonary TB. So, in the initial phases, when CD4 count is higher, generally patients have PTB. As time goes by, it becomes, in addition to PTB, it can be disseminated forms of TB as well as EPTB or extrapulmonary TB. Once the CD4 count falls further to about 300, patients start developing oral candidiasis. Once the CD4 count falls below 200, you have all the serious opportunistic infections like pneumocystis pneumonia, esophageal candidiasis, mucocutaneous herpes, toxoplasmosis of the brain, fungal infections like cryptococcosis, severe infections like diarrhea with cryptosporidiasis. And once the CD4 falls below 50, you have very severe infections like progressive multifocal leukoencephalopathy, cytomegalovirus infections, and Mycobacterium avium intracellular. So if you know that a person's CD4 count is 200, you can give OI prophylaxis to prevent the development of pneumocystis pneumonia, to prevent the development of toxoplasmosis, to prevent the development of cryptococcosis. If a patient's CD4 count is less than 50, you can add agents to prevent the development of infections like MAC. But remember, not all infections can be prevented. You can prevent TB also by giving TB preventive treatment. In India, it comprises of isoniazid prophylaxis treatment or IPT, which can be given to all PLHIVs. So remember, not all infections can be prevented, but a large number of them can be prevented. So if you know the CD4 count, you can expect what kind of infections can happen, and then you can give treatment. You can then give drugs for prophylaxis. It is also important to remember that if a PLHIV presents, say, with fever, and on examination has a CD4 count of say 300, 400, you will consider TB as a diagnosis. You will not consider CMV or severe fungal infections in patients who have more preserved immune functions. Whereas if somebody comes to you with very low CD4 counts, in addition to all these, you will also consider these very different and difficult entities. So it is important to remember that there is a very good association between the opportunistic infections and CD4 counts, and it is on basis of this that our clinical staging was done. This was stage 1 and 2. Here starts stage 2. This is stage 3, and these are stage 4 illnesses. So there is a kind of an association that, and some kind of a one-to-one linkage that you can do between the clinical stage, the CD4 count, and the opportunistic infection. So AIDS, what is AIDS? We have talked so much about this. You will say, madam, you have not told us what is AIDS. We don't use AIDS anymore. There was an entity which was very important called AIDS because it used to define the severity of illness. Now we don't wait for AIDS to develop. We are intervening much before. So AIDS is kind of lost its relevance. But since it was diagnosed as AIDS initially, so it is defined as the stage 4 of HIV illness. So anybody with WHO clinical stage 4 is defined to have AIDS, or anybody with a CD4 count of less than 200 by definition has AIDS. That's all that is there to it. And its hallmark of AIDS is there are presence of more life-threatening events like serious opportunistic infections, malignancies, multiple neurological complications, and other illnesses that can happen when CD4 count falls below 200. Earlier, we used to report the number of AIDS patients that is there, but now no longer. Neither the WHO nor the Indian reporting system uh, calculates or covers or reports the number of AIDS cases that used to happen earlier. But AIDS defined the entire spectrum of the disease, and now it is no longer called AIDS. So you will find many times it is just called HIV infection. Some people still refer to it as HIV/AIDS. So that is, it's become more of a historical entity now. So remember, whenever you talk of or whenever you think of an OI in a patient, you must keep some things in mind. What OI will happen in this patient who is in front of me? It will depend most importantly on the CD4 count. What is the level of immune suppression the patient has? That will define what OI the patient can develop. Whether the patient is on ART or not. Remember, patients on ART also sometimes can manifest OIs, and we will talk maybe at a later date, not today, about this. You must always remember the geographical location of the patient to define the endemicity of any infection. We know that leishmaniasis or Kala Azar is seen in eastern India. So any PLHIV who presents with a large splenomegaly and fever from Bihar, from eastern Orissa, eastern UP, you will think of distal leishmaniasis. You may not think of that as a diagnosis in somebody who is endogenous to Delhi. So that is what it tells you. Then certain other infections like Taloromyces, formerly called Penicillium marnophi, is very geographically limited to an area in the northeast in Manipur. And so you will remember if a patient presents with lesions like that from that area. So it is important to remember the geography when you are talking about OI. So let us look at the classification of some of the opportunistic infections that are seen in these patients. So infections can be bacterial, they can be viral, they can be fungal, they can be parasitic. This just helps you remember them. Bacterial infections, most important is TB. I don't want to overemphasize this, but 50% of PLHIV will have TB in their lifetime, and that is a very important figure to remember and to think about. Other respiratory illnesses include streptococcal infections, bacterial infection with H. influenza and staph, and also intestinal infections with salmonella and shigella. They can be very severe and they can be very disseminated and life-threatening in these patients. Viral infections are very, very prominent in these patients, from varicella zoster, which can cause herpes zoster, to disseminated zoster, herpes simplex, which can cause genital infections, to mucocutaneous infections. CMV can give rise to loss of vision because of CMV retinitis. Human papillomavirus presence with warts is also responsible for cervical cancers. Multiple other viruses like Epstein-Barr viruses, which gives rise to oral hairy leukoplegia and also is responsible for certain lymphomas, and the JC virus, which is thought to be the etiological agent for progressive multifocal leukoencephalopathy. Multiple fungal infections, which can not only be skin and mucocutaneous, but also can be disseminated due to candida, due to pneumocystis, xerovecchiae, also earlier called pneumocystis carinii, cryptococcal infections, Taloromyces, also called penicillium, and histoplasma capsulatum. All of them can happen in these patients. Parasitic infections with toxoplasmosis, multiple intestinal parasites like cryptosporidium, isospora, microspora. Never forget our old friends, Giardia and amoeba, and also leishmania. So if you remember this by bacterial, viral, fungal, parasitic, you can remember them. Another way to remember the number of opportunistic infection is system-wise. What happens in each system? That is another common way to remember them. So how do these patients present with an opportunistic infection? The most common symptoms or presenting symptoms with which PLHIV present with an opportunistic infection is weight loss, seen in about 90% of patients. Almost 90% of them will have fever. Many of them have diarrhea. Almost three-fourths of them will have asthenia. 60% of them will have cough. And almost a third, almost 35% will present with lymphadenopathy. And these are data from Indian clinics. So PLHIV with fever may present with acute fevers, happening for a few days to a few weeks, or we can present with prolonged fevers, which can present as fever of unknown origin. So when you approach a PLHIV with fever, you must ask questions. What history will you ask? What examination will you do? Let us look at that. Acute fevers are generally seen with all other undifferentiated fevers like dengue, malaria, cough, pneumonia, all these can happen. And one prolonged fevers can happen with any of the serious infections like TB, like pneumocystis, fungal infections, toxoplasma, viral infections like CMV, leishmania, histoplasma, malignancies. Sometimes remember, in many situations, HIV itself is the only cause for fever. And the moment you start antiretroviral treatment over a few days, fever resolves. So remember, HIV itself can be the cause of fever. So ask about the duration, type, severity of fever. Ask about the presence of chills and rigors. That will help you tell what could be the cause of fever. Always, like I told you, do the 4S symptom screening for TB. It will help you identify a TB suspect. Ask for diarrhea, breathlessness, skin rash, itching, seizures, oral lesions, genital ulcers, any other swellings. Do a review of the systemic symptoms. Look for a travel history to an endemic area. Look whether patient has taken any drugs from a private practitioner, since they may mask some symptoms, they may modify some symptoms. And so very, very rarely, drug fevers can happen. Do a complete head-to-toe physical examination. Examine all lymph nodes in great detail. Palpate the sinuses. Do an ENT examination, oral examination. Look for skin lesions. Always do genital and perianal examinations. Always look for neck stiffness and meningeal signs. So I don't want to go into this detail, but this is an algorithm which tells you how to approach a patient with prolonged fever. So remember, look whether the patient has cough or breathlessness, means the patient probably has pulmonary symptoms. Try and look for a respiratory tract involvement. If the patient has headache or altered sensorium or seizures, the patient could be having neurological involvement. Try and evaluate the nervous system in great detail. If the patient has lymph node enlargement, you can do evaluation of the lymph node and find out what is happening. If nothing of these is present and nothing else is there, no associated symptoms are pointing to any other particular system, you may need to evaluate these patients on a separate track to find out what is the cause. So this is just an algorithm which is used in our national program for patients who have prolonged fevers. And I've just put it up to you to explain to you that so many examinations and investigations may be needed to arrive at the etiology of fevers. Lymphadenopathy, there can be multiple causes for the lymphadenopathy. There can be TB, most important is TB, many times other viral illnesses. Many fungal infections can cause TB. It can be reactive lymphadenopathy or lymphadenitis because of an infection somewhere in the drainage area. STIs can present as lymphadenopathy, especially inguinal lymphadenopathy due to Donovanosis and chancroid, or also syphilis. Remember, lymphoma, Kaposi, and other metastatic deposits can also present as lymphadenopathy, and there are many other numerous causes of lymphadenopathy. So remember, there are multiple causes of lymphadenopathy in these patients. It has not finished. Multiple, you can actually try and find out the type of disease because of the type of the lymph node that you're encountering. Remember, patients with TB lymphadenitis generally have matted, ulcerative nodes which are fluctuant. Very rarely they are firm. In patients who have other fungal infections, they may, in addition to the lymph node, have skin lesions which are very prominent. Patients with PGL also can have lymph nodes. Lymphomas usually have discrete, separate lymph nodes which are not matted. Diarrhea is the most frequent GI manifestation of AIDS. It is seen in more than 90% of patients from developing countries. Diarrhea, remember, may be due to multiple pathogens. It may be more evasive and the pathogens are more resistant. So remember, whenever a patient of HIV infection comes to you with chronic diarrhea, you must write on your sample to look for organisms, because normally they don't do special stains on stool examination when you send a sample for stool microscopy. They will not do an AFB stain on which these things get picked up. So if you want to pick up the more difficult organisms in your form that you send along with the sample of stool, you must write that patient is a case of HIV infection. We want to rule out opportunistic infections because of intestinal pathogens. Only then will your lab do these tests. So it is important to know about this. Diarrhea can be because of multiple protozoa, Isospora, Cryptosporidium, Giardia, Cyclospora. It can be because of viruses. HIV itself can give rise to diarrhea. CMV involvement, disseminated, especially GI involvement. Never forget Salmonella, Shigella, which also can present as diarrhea. And strongyloidosis, especially among helminths, is seen more to occur in these patients. The main aim in patients presenting with diarrhea is to assess for dehydration and to treat dehydration appropriately depending on whether it is mild, moderate, or severe. Then you assess the nutrition, you assess the other OI medications, and ask the patient about other things. When a patient presents with a history suggestive of a central nervous system involvement, They can present with headache, which can be persistent. It can be mild, it can be moderate, with or without the following symptoms. Always ask for and look for fever, focal seizures, or a neurological deficit like a monoparesis. Assess for signs of meningeal irritation like neck rigidity, photophobia. Look for altered sensorium or if the patient has altered behavior or confusion. Evaluate for memory loss. Always remember that you may need to do a mini mental status examination in these patients. So these are the syndromes of neurological involvement that can be seen in patients with HIV infection. There can be a syndrome of meningitis where patients will present with headache, with fever, with nausea or vomiting and altered sensorium. So this is kind of a global cerebral syndrome. The causes or etiology of meningitis in patients with HIV infections usually are tuberculosis, cryptococcal meningitis, syphilis, and other bacterial infections. Focal cerebral lesions can present with a focal cerebral syndrome comprising of headache, focal neurological signs like a monoparesis, and seizures. So if a patient has seizures and a headache and focal signs, you will more likely to think of focal lesions. The causes of focal lesions are toxoplasma, tuberculomas, primary CNS lymphomas, progressive multifocal leukoencephalopathy, syphilis, and CMV infections. So remember, here you're looking for a mass lesion. Here it is more of a meningeal involvement. So the difference is that when somebody comes to you with a meningeal syndrome, the first investigation you're going to do will be a CSF analysis. If a patient presents to you with a focal syndrome, where you are thinking of one of these agents to present with a mass lesion, the first investigation you are going to do, or the most important investigation for this patient, will not be a CSF examination. It will be neuroimaging in the form of a CT head or an MRI head. Encephalitis can present with cognitive impairment, psychiatric features, and altered sensorium, and most viruses can give rise to encephalitis-like picture. Myelitis means inflammation of the cord, which will present as myelopathy or a cord involvement. Again, in addition to viruses, one must remember toxoplasma and TB can present as tubercular myelitis. If a patient has headache, all right, and presents, if a patient with HIV has severe headache, you will look whether there is presence of fever, neck rigidity, vomiting, altered sensorium or diplopia, and these are meningeal symptoms. Here, the first test you will do is a CSF analysis and send that for analysis. If on the contrary, a patient has focal seizures or signs, to 200s to up to 500. The CSF protein is usually elevated and the sugar is low to normal. You may get a CB-NAT positive in the CSF. If you're dealing with a bacterial infection, you are likely to get a neutrophilic response in the CSF. You will have hundreds to thousands of cells, all of which are neutrophilic. The protein is high and you have very low sugar, which is a hallmark of pyogenic meningitis. You should be able to pick up the organism on a gram stain or if you are subjecting the CSF to a bacterial culture. Cryptococcal meningitis is a very important differential diagnosis of tuberculosis, especially in patients who are having severe immune suppression. Here again, it is a lymphocytic predominance. However, remember, many times the CSF cells may not be very seriously elevated. The protein is mildly elevated, sugar may be low or normal. If you are suspecting cryptococcal meningitis, you will do special tests for that. You will do what is called an India ink preparation. You will also subject the CSF to cryptococcal antigen detection tests. And you can also culture for cryptococcus on a Saber or dextrose agar culture. Syphilis is an important differential diagnosis of chronic meningitis in these patients. They will have a lymphocytic predominant CSF with mildly elevated cells. Protein will be mildly elevated, sugar could be normal, and if you're suspecting syphilis, you will do a VDRL test in the CSF, which may be positive. But always remember, a lumbar puncture and CSF analysis test should be done only after ruling out papilledema, which you can do by clinical examination with a fundoscopy, or in nowadays, we always do a radio imaging, neuroimaging to rule out raised intracranial tension. Before I show you some pictures, we can prevent opportunistic infections by starting patients on ART early so that they don't develop severe immune suppression. Address simple lifestyle measures and reinforce simple lifestyle measures like proper nutrition, safe water, and food habits. To improve upon personal hygienic measures, one must emphasize that one must wash hands before eating and after going to the washroom. Gargling after meals, avoiding raw food and stale food items, and refrigerating the food if it is possible. In patients who have CD4 count less than 300 cells, irrespective of whether or not they are symptomatic, and for anybody with a stage 3 or 4 WHO disease, we give co-trimoxazole prophylaxis for all PLHIV. This is what is called CPT, or co-trimoxazole preventive therapy. Nowadays, any PLHIV who does not have active TB is put on TB preventive therapy with isoniazid preventive treatment. And if you are able, and if you have patient has not been vaccinated earlier, all PLHIV must be vaccinated for hepatitis B. So remember, you must consider geography. And like I said, this is a case which has come to us from RIMS, Manipur. You can see this patient presented with these multiple nodular lesions on his face. There is lymphadenopathy, hepatosplenomegaly, anemia, and thrombocytopenia. These lesions have central umbilications, and this is caused by penicilliosis or Penicillium marnifi, and it is transmitted through bamboo rats, and it's commonly seen during rainy seasons. So the key points to remember about opportunistic infections are they are common in persons living with HIV due to immune suppression. You need to have a systematic approach to examine and evaluate an ongoing OI. Remember the CD4 count and geography before you come to a diagnosis. Most of the opportunistic infections, remember, are treatable, and specific symptoms and signs must give you important clues about the opportunistic infections. It is syndrome based, and you can treat the diseases. Most of them are treatable. Vaccinations can prevent some of them, and good personal hygiene will always help us in the long run. All right, so this is what I wanted some of you to do. Unfortunately, that did not work out. So I want you to tell me and see what is happening. Okay, I think that I missed out on the audio for a while. Is my audio audible now? Am I back now? Is the audio now? All right, good. So Chavi has written down, I'm going to take your name. Chavi has written that this is herpes labialis, and I'm really glad Chavi said that. Yes, so this is a patient, this is a PLHIV who has come to you with a history of fever for 3 days, and you can see that there are patient has complained of pain, and there are lesions which are here at the mouth, at the upper surface of the mouth. You can see that these are vesicular lesions which are here. Some of them are also pustular because they are likely to get secondarily infected very soon. Some of them are there at the angles of the mouth, but they are there here. This is herpes simplex. This is also called due to HSV1, as rightly pointed out by Anisha. So Anisha, Harshita, Bhavika, and many others have said this is herpes simplex. So this is herpes labialis. This is a short duration, 3 days. So what will be the stage of the disease? Anybody? We talked about herpes. Can you now stage this? Yes, Chavi, stage 2. Herpes simplex puts the patient in HIV stage 2. So this is all that is required. Very good. The others are also typing in as herpes simplex stage 2. Very good. So this, if a patient comes to you with this puts the patient in stage 2. Very good. Next, case 2 and case 3. Can you look at these lesions? And can somebody give me an idea as to what is happening? What would be your diagnosis in such a patient? Case 2 and case 3. Anybody? Shingles. Very good. So if you can, a lot of you have got it right. Thank you again. A lot of patience. Excellent. Chavi has also mentioned that this is happening along dermatomes. It is very important to remember that there are these vesicular lesions. Some of these lesions are also hemorrhagic in this patient. And if you see, they are happening along a dermatome. So this dermatomal distribution of these vesicular lesions, which may get secondarily infected if they are very large. So if you see here, the dermatome involved is lower cervical and also thoracic. Here it is more likely to be lumbar, probably also sacral. We are not sure unless we do a full examination. These are herpetic lesions. But remember, herpes zoster can also happen in normal people. It is important to remember here that if it is multi-dermatomal in distribution, that if it is more than 2 dermatomes in distribution, it becomes an indicator as an HIV illness indicator. So it is very important. Good. So you children are doing very well. So case 3 and case 4 are also showing you the same thing. They are showing you more extensive disease here. You can see this fluid filled cavities, lesions, which are there. Here also these lesions are there. Very good. Kiran Jot has identified these also. These are also multi-dermatomal in distribution. If you have such extensive lesions in a patient who presents to your skin OPD or dermatology or medicine OPD without ever having been tested for HIV, such patients should be tested for HIV. And as Kiran Jot has pointed out, this again puts the patient in stage 2. Kiran Jot, is it stage 2 or will it go to stage 3? Zoster. All right, stage 2. We will go stage 3. All right. Um, Zoster is usually acute only. Zoster does not have chronic manifestations. Simplex can have chronic mucocutaneous disease. Zoster generally does not have a chronic phase, unlike herpes simplex, which can last for weeks to months. So it is important to remember that. All right, let us look at case 4 and study 5. First, let us talk about 4. What can you see in 4 and what can you see in 5? Yes. So I have my friends who are pointing out some diseases. Very good. Excellent. Many students are typing in that these are lesions of thrush, also called candidiasis. Very good. So if you can see these lesions, these are happening on the upper part of the jaw in stage 4. They are also there on the inner side of the lips. Very good. I will very good. Most students have identified it. Very good. So they are also happening on the inner side of the lips in this patient. We are not having access to the oral cavity here. So since it is oral lesions, this becomes oral candidiasis stage 3. Case study 4, from what we are able to see, is oral candidiasis stage 3. If you look at stage 4, it is far more extensive in stage 4. What is happening is you can see that there are these lesions on the tongue, on the dorsal surface. There are also the lesions on the soft palate. You can also see the lesions in the fauces. If you can see the fauces here and possibly extending downwards. So this becomes pharyngeal to esophageal candidiasis. So stage case study 5, sorry, becomes stage 4, because if this patient has pharyngeal or esophageal candidiasis, it becomes stage 4. Whereas case study was constricted or limited to the oral cavity, so that is stage 3. So this is how the difference between case study 4 and case study 5 is. So that is stage 3. This becomes stage 4. So like Jaya has said, this more likely is oroesophageal candidiasis. This more likely is oral candidiasis. That is why you must do a detailed oral examination in all persons living with HIV infection. Case study 6. If you can see case study 6, the dorsum of the tongue is not showing anything. But if you look at the lateral ridges, you have these vertical lines going down, right? So these vertical lines, very good, which are happening along the lateral border of the tongue, is what is called oral hairy leukoplakia. Many students like Bhavika, like Alisha, like Ishika, Mehak, I'm not going to take more names, but a lot of you have correctly identified case study 6 as oral hairy leukoplakia. So oral hairy leukoplakia, what stage? That's the next question. From your table, if you have your table in your hand, can you tell me? Oral hairy leukoplakia is stage 3. So see how a small lesion on the lateral side of the tongue has put your patient in stage 3. It's very important to recognize that. Good. Let's go to stage 7. So this is a 28-year-old male who presented with fever, cough, sputum, hemoptysis, and the upper zone of the chest X-ray is suggesting a cavity in the left upper zone area. So suppose this is TB, which is most likely diagnosis. Remember, it can also be fungus. But if it is TB, it is what kind of TB? It is pulmonary TB. So if it is pulmonary TB, what stage? Very good, Bhavika. Pulmonary TB becomes stage 3. So the formation of a cavity tells you, very good, Matisse, very good. There are many other children who are typing in. Dr. Harsh, maybe you would like to look at it again. TB becomes stage 3, not stage 2. Pulmonary TB is stage 3. Extra pulmonary TB becomes stage 4. So this is pulmonary TB. And so, as you can see, cavities happen when patients are mounting an immune response. So cavitary lesions happen in patients who mount immune responses. So that is why this patient's immune system is relatively well preserved to mount an immune response. So pulmonary TB becomes stage 3. Very good. What about this? This is a 39-year-old PLHIV who presented with history of fever, appetite, and multiple matted glands in the neck. What is your possible diagnosis? Matted glands. Most likely diagnosis. Again, the kids are typing in very well. It is TB lymphadenitis. Matted lymph nodes generally is TB lymphadenitis. There can be other differential diagnosis to the lymph nodes also, but you will have to. No role of CD4 counts in staging, not required. CD4 counts are not required in staging, Dr. Harshita. This is a clinical staging. We are staging it clinically. So it is a WHO clinical staging. All right. So like somebody has quoted it, you have to rule out a lymphoma, an NHL, everything in this patient. You will get an FNAC done. You are not going to go by your clinical diagnosis that it is matted, so it is TB. No, you will still get an FNAC done. Yes, it could be any other malignancy. It could be an oral cavity malignancy with a large lymph node draining. But if it is TB, my question was, if it is, because it is matted, it is more likely to be TB, but you will still get a fine needle aspiration cytology. You will still subject it to a CBNAT, and then you will establish your diagnosis of whether this lymph node is TB or non-TB. So if you have TB lymphadenitis, it becomes stage 4 because TB lymphadenitis is extra pulmonary TB. So it goes on for stage 4. Very good. Many of the kids have recognized this as stage 4. Excellent. Now we will go further. So this microscopy picture was done from a stool specimen from a PLHIV who presented with chronic diarrhea. So this stool sample was stained with Zeal-Nielsen or modified ZN staining, and that revealed these acid-fast cysts. All right. So these acid-fast cysts will make you think that this could be one of the more difficult organisms. Somebody has actually also put up isospora, and I agree. From this, it is very difficult for us to say whether it is cryptosporidium or isospora, but you need to know the size of these to be able to differentiate. Isospora are slightly bigger in size. Microspora are even bigger, and isospora are also slightly oval. So these rounded cyst-like organisms are more likely to be cryptosporidium, diarrhea. Nocardia is also at AFB, like Ishika has put up, but nocardia does not produce cysts. Nocardia produces AFB or acid-fast bacilli in chains. It does not produce cysts, and GI or diarrhea is not a prominent manifestation of nocardia. Nocardia is more likely to manifest with lung involvement. Pneumocystis usually does not involve the GI tract. It is usually confined to the respiratory tract. So this is a stool examination of a patient with diarrhea. You will not suspect pneumocystis. You are likely to suspect isospora, cryptosporidia, microspora. And if you are able to get these rounded cysts, you will think that it is most likely to be due to chronic diarrhea due to cryptosporidium. Very good. Again, stage, clinical stage. If it is cryptosporidium stage, one person has written stage 4. Very good. So now everybody is responding that it is stage 4. Well done. So it's likely to be stage 4. Next case. PLHIV 32-year-old female resident of Manipur who presented with fever, cough, body ache, loss of weight, loss of appetite, and multiple facial papules which were present. If you can see, yes, if you can see that this patient has these multiple papular, coalescent, some places even nodular lesions all over the face. Now, the clue here was the patient is a resident of Manipur. So, all of you are writing down this is Talaromyces or Penicillium fungus, which is giving rise to Talaromyces or Penicillium barneffi infection. So, you will do an FNAC from this and then establish the diagnosis. Stage 4. So, one girl has asked a question, can these be papular pleuritic regions? So, I was going to come to that question that suppose patient was not from Manipur. Suppose patient was from Delhi. Then what will you do? Suppose this lady was a resident of Delhi and has never gone to Northeast. What will your differential diagnosis be? Nobody? Oh, all right. So now I am getting the answers. Then somebody is saying it could be papular pleuritic lesions. Somebody is saying I cannot tell you what it can be. You have to do the histopathology. Fantastic. Somebody else says it is molluscum contagiosum. One other person has said it could be cutaneous cryptococcosis, and all of you are right. So you have a differential diagnosis for papular nodular lesions on the face. These are not papular pleuritic eruptions. PPE never is nodular. So please remember, among your differential diagnosis, it can be cutaneous crypto, it can be cutaneous candida, it can be molluscum, it can be any other nodular lesion like fungal infections, but it cannot be PPE. Papular pleuritic eruptions are never nodular or coalescent. So that is not one of the differential diagnosis. But here, in a patient from Manipur with these, I agree it will be stage 4 clinical disease with a suspicion of um, Talaromyces or Penicillium barneffi. I'm going to go further. This was a patient. These are patients. All these pictures are from India. Yes, umbilicated, absolutely. Chavi has asked a question, madam, will umbilicated lesions, they are not umbilicated, but will it still be there? Yes, for the earlier picture, it will still be there as a differential diagnosis, and I will show you more pictures as you go by. So this is a patient who has presented. So I was telling you that all these pictures are from our National AIDS Control Program. And these are the slides that we use for training of our medical officers as part of their training curriculum. And I'm just showing you, and I have borrowed these slides so that I can show you the same thing that we teach them. So what do you think is the lesions? So if you see these lesions are there here, they are also here. They are here in the hairy parts of the patient, and they are not very characteristic. They are neither nodular nor they are having any specific morphology. So you will think this because it is in the bearded area and in the hairy area, you will think this as seborrheic dermatitis. Absolutely right. Two of you have identified it correctly, Chavi and Harshita. Good. So this is a patient with more are identifying it. Good, Madhav. So this is a patient with seborrheic dermatitis. Seborrheic dermatitis is what stage? Stage 2. So now remember, whenever you have a patient who has multiple manifestations, you will not go by the whatever, you will go by the manifestation which is most severe to give you a diagnosis or your staging. So if this patient on the left, if you see, has very severe wasting, you can see his zygomatic arches are so prominent. He's having so much of wasting. He has HIV wasting syndrome. He probably has oral lesions as well, in addition to the seborrheic dermatitis. You will take the disease which is most severe to give you a diagnosis. But here, if there is only seborrheic dermatitis, then that will give you stage 2. If there is HIV wasting as well, what stage will that become? HIV wasting as well, stage 4. Very good. So if a patient, so remember, very good, all of you have identified it. So if you remember that If a patient has multiple clinical manifestations, the manifestation which puts the patient at the most severe stage of illness is what you will take as the staging, though there may be manifestations which could be pointing to an earlier stage also. All right. Yes. Anybody? Can you look at these lesions and can you give me some idea of what is going on? Two persons have answered to it. A third person has given me a very good answer. So if you look at these lesions, these are also similar to, almost similar. They're not similar, but they look like the lesions of that lady from Manipur. These lesions are there all over the body. They are there on the eyelids. They are near the eyes. They are there on the face. These are nodular lesions. They are not papular. They have gone beyond nodular lesions. And as some of you have very correctly pointed out, if you look, some of them in the center will have a depression. These are what are classically called umbilicated lesions. They have a depression. I am pointing, I don't know whether my pointer is being seen by you, but many of these lesions, especially this one, these ones, the ones which is here, are having a central umbilicated lesion, umbilicated depression in the center. Perfect. That is what one of you has identified. So the first, these lesions are there on the face. Remember, many times these lesions are also there on the genital area. So you must look at the genitals also of these patients for lesions. So the first differential diagnosis of such lesions is always molluscum contagiosum. But remember, it is a differential diagnosis. Penicillium marnifi, cutaneous cryptococcosis, cutaneous histoplasmosis, rarely Kaposi sarcoma. All of them can present with nodular lesions just like this, sometimes also with central umbilication. So you must have a list of differential diagnosis. So though the most likely diagnosis in this patient seems to be molluscum contagiosum. Very good that all of you have identified it. And so this would be stage. Kids, what stage will this be? Stage 4. Correct. So this is likely to be stage 4. Very good. So most likely this is going to be stage 4. This is a condition where you can see that there are these lesions which are there in the hands and on the feet, also in the legs. They are not nodular, but they are papular. And if you can see that the patient has scratched on them so tremendously, so probably they are itchy lesions. This is, yes, this is papular pruritic eruption. Somebody pointed out, can this be scabies? It would have been scabies had they been limited to the hands and the feet and had not involved the legs and had not gone proximally, because scabies usually involves the interdigital area and to some extent the hand and feet, not on the dorsal surfaces but all on the palmar surfaces. In patients with HIV and other immune suppressive diseases, it can also involve the face in what is called a Norwegian form of scabies. But this kind of disease is papular pruritic eruption classically. Differential diagnosis may include cryptococcosis because it also produces more papular lesions, but it can also cause nodular lesions. So remember, they are just a differential diagnosis, but the most likely diagnosis, because of the pruritic nature of the illness, is papular pruritic eruption or PPE. Remember, any patient with HIV must be tested for a STI, and this is a patient with STI who's showing a urethral discharge. So what are the common causes of urethral discharge? Anybody? Urethral discharge in a male, most common cause. Syphilis does not cause so much, yes. Gonorrheal infections will likely to cause gonococcal urethritis presence as urethral discharges, and some other infections which are non-gonococcal can also cause urethral discharges, but not syphilis. What is the classical disease, classical lesion seen with syphilis? Yes, it can, in the primary syphilis, it is a chancre. In secondary syphilis, In secondary syphilis, primary disease you've identified, it can be a chancre. In secondary syphilis, condylomata. Have you heard of condylomata? It can be a rash, absolutely. It can be an erythematous rash. Yes. Gamma comes much later. Gamma is stage 3. Very good. Somebody has identified a gamma. Gamma is stage 3, but this is a urethral discharge, as you can see in this patient with a penile discharge. Here also you can have multiple pyodermas which can happen in these patients, and multiple soft skin and soft tissue infections can happen because of Staph aureus. Stage. Oh, somebody has asked me what are the lesions in the hands in the previous. Remember, gonococcus can also spread in the bloodstream and can give rise to multiple lesions in the hands and other areas of the skin as well. So this could be disseminated lesions. So what about the stage here of skin lesions? Yes, if it is not chronic, it becomes stage 2. If it is lasts for many more than a month, and it can be stage 3 as well. But here in this, because of impetigo, eczema, furunculosis, multiple skin lesions, can this be HSV? Can this be HSV? No, these lesions are not vesicular. HSV lesions are always vesicular. They usually happen on the glans penis. This is not the area where HSV happens. Usually it is a recurrent disease which happens on the glans. So this is unlikely to be because of HSV. What about this? What are these lesions? Yes. So Kiran Jot has identified this as fungal diseases. Some of you have written down a more scientific term of onychomycosis. Wonderful. So this is all onychomycosis. Somebody has already staged it as stage 2. So if a patient with HIV infection presents with this kind of fungal infection, which is involving the hands, here if you see it is limited to the nail, but in this patient if you see it is also causing a significant amount of soft tissue damage around areas. But fungal disease, fungal nail infections or onychomycosis as it is called, will put the patient in WHO stage 2. Right. So here is a patient who presented with a history of mild fever for 15 days and has presented in altered sensorium. On examination, the patient is unconscious, not responding to verbal commands. The patient's physical examination finding is shown to you, and there is some terminal neck rigidity which is present in the patient. Terminal neck rigidity. So looking at all these things together, what will be your first possible diagnosis? 2 people have given me a diagnosis, 3, 4, 5, all right. Let us look at these diagnoses. One person has mentioned this is HSV encephalitis. Yes, I would have kept the possibility of HSV encephalitis, but it has a more dramatic picture. It is an encephalitis, so usually seizures are present. And HSV cannot account for these lesions. If you look, these are again small nodular lesions. Some of them have even having an umbilication. Usually, this is not the type of lesions which are seen with herpes simplex. Herpes simplex produces vesicular lesions. Cryptosporidium generally doesn't involve the skin, but a lot of you have said this can be cryptococcal infections. So these are cutaneous cryptococcal lesions along with cryptococcal meningitis. So this patient could be having disseminated cryptococcosis, and that is a good differential diagnosis to think about. You will do a lumbar puncture in these patients and then subject it to an India ink preparation, and you will also subject it to a cryptococcal antigen test, where you may be able to find out the patient has cryptococcal infection. And you can also look for cryptococcosis if you do from a smear from these lesions. So like I was telling you, umbilicated lesions, though very prominently, are seen in patients with molluscum. They can also be seen in patients with cryptococcal. This is cutaneous crypto. Somebody put up a diagnosis of toxoplasma. Toxoplasma can probably explain your cerebral lesions. But toxoplasma, A, does not usually present a meningitis kind of illness, and B, it will not explain your skin lesions. So if you want to explain your skin lesions and your meningitis together, you will have to keep a diagnosis of cryptococcal disease. Somebody has already put, like Dharia has put, that this patient will probably have stage 4 HIV illness, and that is correct. So you will do more investigations. But you will think that since patient is already having a meningitis, it will put the patient into stage 4. You don't have to wait to find the organism here. So that directly puts the patient onto stage 4. And if this turns out to be cutaneous crypto as well as cryptococcal meningitis, the patient will definitely be in HIV stage 4 disease. Another picture of another patient. So this patient seems to be from Northeast. Here also you have nodular lesions. Here also you have umbilicated lesions. I'm just trying to show you these pictures again and again to show you that penicillium can also be like this. Cryptococcus can also be like this. Molluscum can also be like this. So skin disease needs to be evaluated with skin lesions need to be evaluated with great care in patients with HIV infection. Chavi has also pointed out that since the patient is from Manipur, the picture is from RIMS Manipur. So it is likely to be penicillium. And I agree with you. My only point of putting up this picture here was that if you have skin lesions, please go by the morphology of lesions. They are very important, but you must have a list of differential diagnosis, and they need to be skin lesions provide multiple clues about what can be the cause of the lesions. Kaposi sarcoma is a very rare disease which is seen. In my so many years of HIV care in my clinic, I have now the in charge of the HIV clinic for many years now, and we have been running an ART center at our hospital for more than since 2004. We were the first ART clinic to be started in the country. I have only seen 2 patients of Kaposi sarcoma indigenous to India now. So it is not very common in India. It is more common in patients from Europe. It is also very, very common in patients who have MSM behavior, that is men having sex with men. So it is not a heterosexually transmitted disease. So here also, if you can see, there is a violaceous lesion which is there on the upper eyelid. These are highly vascular lesions. So this small lesion can be Kaposi sarcoma. Remember, if this had presented in the face, you would have thought of some other of the diagnosis of that. These are other examples of Kaposi that were seen by JJ Hospital in Mumbai. If you can see, there is this violaceous lesion which is present in the hard palate. And these are lesions which are seen, nodular lesions, very strangely, which are seen in the foot of this patient. So remember, in India, because of the color of our skin, you may not see such brilliant violaceous erythematous lesions. You may see more darker lesions like this one. And again, histopathology of lesions is a very, very, very important for managing these patients. So like my last slide is showing you this regarding this, that here you have 3 lesions. This lesion is molluscum contagiosum. This lesion turned out to be cryptococcus. This lesion turned out to be penicillium. So look at the morphology. They look almost similar. Here also there is a central umbilication. Here also there is a central umbilication. This is a much larger lesion with central ulceration and umbilication. These are from 3 different areas of the country. So you must remember that they morphologically can look identical, and so you must have a differential diagnosis. Am I audible? Am I being heard? Because you have become very quiet, all of you. I don't think I'm. Yes, I'm being heard. Good. All right. Good. Thank you. Thank you, please. So remember, you should never forget that these patients can have ocular involvement. Ocular involvement sometimes may be very subtle. So sometimes patients who are very sick and very ill, they will notice some mild blurring of vision, but they may not report it to you because they think it is part of general debility. So sometimes you can have very serious illnesses like this. We have seen many patients with CMV retinitis, a lot of patients. Somebody has actually mentioned that it appears like a pizza sauce. This is what is called. It's called a tomato sauce or a tomato pizza appearance. These patients tend to lose vision very dramatically and very rapidly, and it spreads from monocular involvement to binocular involvement very quickly, and the loss of vision is permanent in these patients. So this is a classical example of CMV retinitis. We have treated many patients for CMV retinitis with ganciclovir, and you get good response if you think about it and you treat it. That somebody said splash tomato, absolutely. Tomato sauce, pizza sauce, these are some of the descriptions which are given to the fundus picture of these patients. I'm going to stop here as my last slide. I told you that there are some strange OIs that can be seen in these patients. This is a slide which was given to me by my friend from BHU, Dr. Jaya. If you can see, this is a PLHIV which is showing multiple LD bodies. So you should always think of visceral leishmaniasis and Kara Azar in these patients. Eastern India is where you find histoplasma. Histoplasma is prevalent along the Gangetic belt, especially in West Bengal. And this is a patient of HIV infection who had this multiple ulcers and ulcerative lesions, if you can see, which is involving the lower part of the face, the lip, and also the mouth. On examination, they turned out to be histoplasmosis. So whether patient has leishmaniasis or histoplasmosis, or in the earlier side, patient had retinitis, what stage does that become? Clinical stage. That becomes very good. So many of our students are now giving me the answer that it becomes stage 4 HIV illness. So this is what I wanted to impress upon you, is that once you do a detailed physical examination of the patient and reach a differential diagnosis, or reach a diagnosis and form a list of differential diagnosis, you should be able to stage your HIV infection. Earlier, treatment depended upon the stage. We would treat stage 3 and 4, whereas we would wait for stage 1 and 2, but not now, not anymore. Nowadays, the recommendations of the World Health Organization and of National AIDS Control Organization, Government of India, are anybody who is detected to have HIV infection, irrespective of clinical stage, irrespective of gender, irrespective of CD4 count, needs to be started or initiated on antiretroviral treatment. All right. So anybody, you will start treatment, but stage 3 or 4 tells you that patient has far more advanced immune suppression as compared to stage 1 and 2. Why is that important to know? Because patients with stage 3 and 4 tend to have much higher mortality even after starting HIV. And this subgroup of patients has recently been defined as patients with advanced HIV disease. It is a new term which has been coined by WHO 2 years back, and Government of India has now focused patients with advanced HIV infection as a priority for care among all PLHIVs. So anybody with a CD4 count less than 200 and or a WHO 3 or 4 stage illness becomes a patient with advanced HIV disease. These patients tend to have poorer outcomes, more mortality, much higher likelihood of developing TB, and also these patients are also less likely to mount very good immune responses once you start them on antiretroviral treatment. So our aim must be to evaluate and to get patients with HIV infection as early as possible, especially when they are asymptomatic, and put these patients on antiretroviral treatment as soon as possible. So I'm going to stop here because my rest of the session was going to talk about individual OIs. I don't think we will be able to talk about individual OIs here. Let us talk about, told you about clinical examination in these patients. So there was a question by one of the students that, ma'am, what to do if during assessment we see the patient is not ready for ART? That is perfectly good question to ask, and we know that many times our patients are not willing to start ART. The moment they come to you, you tell them you have HIV, and then you say, now tomorrow I'm going to start you on ART. Patient says, look, I need to think about this. I am not sure, मेरे को तो कुछ है नहीं, especially the asymptomatic ones will say, मुझे तो कोई problem है ही नहीं. I have no problem. I don't want to start ART. I'm going to think about it. So what will you do? You can't force the patient to start ART because the patient has to be compliant to your ART for a very long period of time. If he's not in your corner, he's not going to work with you. So what are you going to do? You're going to explain and counsel the patient. That's why all the ART clinics have ART counselors who counsel the patient and explain to the patient to need to start ART. If the patient is not willing to start ART, you should ask the patient, go home, think about it, and come back. Come back to us when you're ready to start ART. In the meantime, you should support the patient by giving counseling. You should give a phone calls to the patient, ask your community care coordinator to work with the patient. So you should try and bring the patient back into the system as soon as possible and start ART. Many times we have patients who say, let me try other forms of treatment, yoga, some other Baba cure, something. Many times patients have many issues starting ART, but you must always impress upon the patient that ART is the one which is going to provide you longest longevity and survival. So it is in your best interest that you start ART now, but you must try and counsel your patients. Will patients with tuberculoma present with fever? Patients with tuberculomas may present with fever, they may not present with fever. The presence of fever in a patient who presents with a ring enhancing lesion gives you more credence to the diagnosis of tuberculomas, but it is not necessary that anybody with tuberculomas will have fever. They can present without fever as well. These were the two questions that I think remain unanswered. Most of them I have gone on to answer. If there are any other questions, would anybody like to ask anything else? No? Okay, good. So I had a good interaction with you all. I was able to ask questions and you were able to answer that. And I'm really glad we did it this way. So thank you very much for your participation today. And I'm going to end this session here. Thank you very much. Bye-bye.